Very good morning to all of you. Welcome to another episode of Sri Knowledge Academy weekly Sunday webinar series. Today we have a very interesting topic and a very timely topic which we encounter daily in our clinical practice, breast cancer. Before going on to the lecture, let me remind you of some housekeeping rules. The webinar link will be open for you to join in from 9:15 to 9:45 a.m. and no late attendees will be permitted thereafter. You have to stay until the end of the lecture to obtain the e-certificate and the CPD points. Kindly keep your mics and videos turned off during the lecture. You can ask any question at the end of the lecture. You can type it in the chat box. Now, let's go to the today's topic. Today's topic is breast cancer, and our guest lecturer is Dr. Buddhika Thilakarathna, consultant oncological surgeon, Teaching Hospital, Batticaloa. He obtained his MBBS from University of Colombo in 2009 and completed his general surgical training from 2014 to 2017. Then he worked as a senior registrar in oncological surgery for 2 years in Sri Lanka and completed his overseas training in UK for 2 years again. Currently, he working as a consultant oncological surgeon in Teaching Hospital Batticaloa, serving this country. Dear sir, over to you to conduct your timely lecture. Thank you.
Very good morning to everybody. My name is Dr. Buddhika Thilakarathna and I am working as a consultant oncological surgeon at Teaching Hospital Batticaloa. First, I would like to thank Society of Society for Research and Health Innovation for giving me this opportunity. Actually, we were planning to do this lecture during the month of breast cancer awareness, that is in last October, once my good friend Dr. Thanikawasan has invited me to do this lecture. But due to the various reasons, we couldn't carry out during the last 2 months, but finally we are here. So shall we get into the lecture now? And during the next 1 hour, 1.5 hours time, these are the lineup topics that we are going to discuss. We are going to discuss briefly about what is a cancer and something related to cancer epidemiology globally as well as in Sri Lanka. This will give you idea about what is the importance of knowing about breast cancer and something related to breast cancer screening and how to identify breast cancer symptoms and signs. And how to investigate suspected breast cancer, which will be very important for you in day-to-day practice, and the different methods of treatment options, and lastly the post-operative care. So what is a cancer? Let me start it like this. It is a known fact that some people assume that about 1 million cells are dying in a second in a normal human body. So in other way around, 1.2 kilograms of cell debris are shed from each body in every day. But nothing to be worried. But because all these dead cells are replaced by the process called cell division. But this process of cell division has to be regulated and controlled in a very precise manner. Otherwise, what will happen is there will be functionally as well as structurally abnormalities when we have a excess growth of cells or reduced growth of cells. What happens in cancer is because of any damage to the genetic material. This genetic material damage can be occurred due to it coming from your parents genetically, or it can be occurred de novo when you are living when you are living. Whatever the reason, when there is genetic damage is happen, this regulated control division of cells is disrupted. So result is happening of uncontrolled division of abnormal cells. So this is what we call a cancer. The other main feature of a cancer is these cancerous cells can infiltrate around to the surrounding tissues, as well as it can infiltrate into the blood vessels and the lymphatics and travel through the blood vessels and lymphatics and go and deposit somewhere else. That is called the metastasis. So these are the main features of a cancer. So there is an uncontrolled division of abnormal cells in a part of the body, as well as it can be metastasis. So what will happen is at the end there will be functional as well as structurally abnormal cell growth in a part of the body. If you get on with the world cancer epidemiology, according to 2019 WHO data, it has been estimated cancers are the second commonest cause of death worldwide. The commonest cause of death in the worldwide is the cardiovascular disease, myocardial infarction, and related cardiovascular disease. But cancers are the second commonest cause of death worldwide, according to WHO data. According to the 2020 WHO data, cancer is accounting for nearly about 10 million deaths in 2020. Out of these 10 million cancer deaths, like most common cancers reported were, if you take according to the numbers, breast cancer is lying in the top. So second commonest cancer reported is the lung, and the colon rectum is third, prostate is fourth, and the list goes on like that. The most important thing to be understand here is the most common cancer reported in worldwide is the breast cancer. So this one I have taken from the internet WHO website. That is, you can here also you can see that WHO has given the numbers. In 2020, the most common cancer is the breast cancer reported, and the list goes on like lung cancer, colorectal cancer, prostate, stomach, liver, like that. Even though the breast cancer is the most common cancer reported, it is not the most common cancer death. It is not the cause for the most common cancer death. So according to WHO data, in 2020, most common causes of cancer death are the lung cancers, colon and rectum, third is the liver, stomach, and the breast has taken only the fifth place. And each year, approximately 400,000 children develop cancer. But it is a common fact that the common cancers vary between region to region and country to country. Unfortunately, nearly half of the cancers are estimated to occur in Asia, according to WHO data. You can see in this pie chart, nearly half of the cancers are estimated to occur in Asia. Unfortunately, as a Sri Lankan, we also living in the Asian continent. And the second is Europe, and third is North America, and the list goes on like that. This is another way of depicting the detection of cancers in the world map. You can see how densely the cancers are concentrated in the Asian region, especially in the Russia and the China and the southeastern countries of the Asia. Fortunately, even though Sri Lanka is situated in the Asian region, you can see the Sri Lanka has a less number of cancer incidents compared to the other Asian countries. This is a bit of a frightening graph that is published by the WHO. They have predicted the increase of breast cancers, detection of breast cancers next 20 years. So we all know that in 2020, they have detected about 2.2 million cases of breast cancers. But they have estimated in 2040, in 20 years time, this number will be double. So it is more than 4 million. So there will be a steep rise of breast cancer detection in the next 20 years as well. So we have the most common cancer of breast cancer today, and also it will be steeply rising over the next 20 years as well. And other unfortunate thing is this most number of breast cancers are predicted to occur in the next 20 years are estimated to happen in the Asian region. You can see compared to the current number of breast cancers, there will be about 60% increase of breast cancers detection in only on the Asian region. Now that is the world cancer epidemiology. But if we get on back with the Sri Lankan cancer epidemiology, that is, I have based these next few slides based on the cancer incident and mortality data Sri Lanka in 2020 published by the National Cancer Control Program. So the latest data we have available is 2020 data. According to that data, in 2020 in Sri Lanka, there were about 37,648 cancers were reported. In males, around 17,500, and females around 20,000. So in other way, I can say that In other way, it says that each day in Sri Lanka, 103 persons are diagnosed with cancers. This is not only the breast cancer, but overall in cancers, in a single day, in every single day, 103 person is diagnosed with cancers. Now, if you break down into the size by the section, if you get the female, the most common cancer, the commonest cancer is the breast cancer. That is comprising about 1/4 of all the cancers that is diagnosed in the females. Second commonest cancer in females is the thyroid cancer, and that is only 12%. And the colon, rectum, third, uterus, fourth. The list goes on like that. But this is bit contrast when we come to the males, as the males doesn't have much of breast tissue, and various other carcinogens are in the males. The commonest cancer in the males are the oral cancers. Maybe because of the alcohol use, maybe because of smoking, maybe because of beetle chewing. Whatever the reason, the commonest cancer in the males is the oral cancers, and the second common cancer is the lung cancers, and the third is colon, rectum, and the fourth is esophagus. The list goes on like that. So as far as the females are concerned, most frightening thing is most common cancer in the females is breast cancer, which is 1/4 of all the one fourth of the cancers from all the cancers that can be diagnosed in the females. I would like you to consider more on the lower down chart here, bar chart here. That is the crude incidence rate of leading cancers in females in Sri Lanka in 2020. That means the crude incidence rate per 100,000 population. So if you get 100,000 population, there is a very high chance in the breast cancers can be occurred in 45.9. That is when you compare with the second commonest cancer, thyroid cancer, that is only about 20.4. So in other way around, it is more than 2 times the second commonest cancer compared to the thyroid cancer, the occurrence of breast cancer. You can see how long is the bar breast cancer bar compared to the thyroid bar. This again a bit of a very important slide. You can see the rise of detection of breast cancers according to the age-specific incident rates of breast cancers in Sri Lanka in 2020. This is a common apprehension, common feeling of the general population. The cancers occurs when you grow older, like 40 years and 50 years, 60 years. Likewise, it is true that the majority of cancers are detected at the old age, but the occurrence of cancers, especially the breast cancers, has started at the age of very young age. According to this chart, you can see the breast cancer has started to rise by the age of 25 years of age at least. Even in my clinical practice in Batticaloa, even I have encountered about more than 5 females who is diagnosed to have a breast cancer less than 30 years of age. And one such female patient is already had the metastasis. So that is the danger of the situation. So breast cancer start to rise very early stage, as much as 20 years, 25 years of age. Age standardized incidence rates of breast cancers again is rising over when you compare with the 1985 and when you compare to the 2020, there is a steep rise of age standardized incidence rate as well. When you get on with the cancer incident data, according to the district, majority of breast cancers are accumulated according to this chart, in the western province, especially in Colombo. Maybe because of the majority of the people are trying to get the medical services from maybe Apex Hospital, Maharagam, or the National Hospital. That may be the reason in a way, but somehow the cancer detection has mostly seen in the western province, especially in Colombo, Gampa, and Kalutara. But there are some pockets of increased incidence of breast cancers in the other part of the country as well, such as Kurunegala, Kandy, Trincomalee, and Jaffna. This is a very interesting research retrospective analytic study which is published in 2020 by Dr. Janatha Balawardena and Dr. Nura Joseph and team. That is breast cancer survival in Sri Lanka. According to that research, they have shown the percentage of patients present with de novo metastasis. That means that at the presentation, the percentage of patients who had the metastasis, that is about 14%. And 18% of the patients are presented with locally advanced disease when they presented to the medical attention. So there is a significant number of patients is at the locally advanced disease as well as the metastatic disease by the time they presented to the seek for the medical advice. And very sort of unfortunate thing here that we have to improve on, like only 3% of the patients with localized breast disease were treated with breast conservation surgery. So these patients could have treated with majority of the patients could have treated with breast conservation surgery that we can preserve the breast, but only 3% who are eligible for breast conservation surgery has been treated with breast conservation surgery. So that is something that as surgeons that we have to look into. The 5-year disease-free survival rate was 71.6% in patients with localized disease. If you get the metastatic disease, progression-free survival was about 20 months, while the median overall survival was 30 months. So basically what I'm saying is, if the patient is having metastatic disease, survival would be around either 2 years or 3 years in average. So why should we worry? So I think you have the answers for the question that is on the screen now. Why should we worry about the breast carcinoma now? So just to recapitulate again, the breast cancer is the most frequently diagnosed life-threatening cancer in the woman, leading cause of cancer death in women, a major health issue globally, 2 million new cases annually in globally, 400,000 annual deaths, 4.4 million of the people are living with the disease at the moment. And this is another interesting statement. If you get six female friends together, there is a risk of one female is developing a breast cancer during their lifetime. So if you have if females have 6 female friends get together, and there is a high chance there's one person in that group will develop a breast cancer in their lifetime. So this is very frightening. So we know this is now it's a problem on our hand. So as a healthcare professionals, what we should do? There are a lot of things that we can do. The main things that we can do is we can go for the public awareness. I will talk in a bit about this, and the screening, very important, and increase and easy access to the medical treatment, optimal medical management, and the close follow-up. We will discuss about these things in the next 20 to 30 minutes time. Breast cancer public awareness. So it has been, because the whole world knows about the importance of knowing of the breast cancer and the treatment of breast cancer. Because of that the whole world has a separate month. I think none of the cancers has given that much of importance, separate month for the breast cancer awareness. That has happened, that is named in October, that is the breast cancer awareness month. You have been seeing a lot of surgeons, oncosurgeons and oncologists are coming to the television, coming to the radio, and giving the lectures and educate the public regarding the importance of knowing the breast cancer. Another thing, there are in the breast cancer awareness month, there are a lot of walks and a lot of talk, regional meetings to aware the public about the breast cancers. These are some of the public awareness that I have made during my after I'm coming to Sri Lanka. In my opinion, we shouldn't stick to only to 1 month for the breast cancer. It's very important. It's okay to have 1 month, but as medical officers, I think whenever you feel that these females needs knowledge about breast cancer, spend about 1 minute or 2 minutes when they encounter during the clinic visits and educate them regarding and encourage them to go for the screen. So what is screening? So from the medical student time, that the definitions are a bit complicated for us. So it is same for the screening as well. The definition of screening is the application of medical procedure or test to people who as yet have no symptoms of a particular disease for the purpose of determining their likelihood of having the disease. So nothing goes to your mind, I know that. But but simplified version is screening is detection of patient who has the disease before they develop in the symptoms and signs. So what are the options? Before that, who are the people we should screen as far as concerning the breast cancers? I think you can remember even in Sri Lanka, the breast cancers are start to rise by the age of 25 years of age. So it is same for the world as well. Because of that, several guidelines in the world, such as NCCN guideline, which is in UK, and the ESMO guidelines in Europe, NICE guidelines, all these guidelines have recommended to start the screening at the early age. Rather than waiting for 40 years and 50 years, start the screening at the age of early stage. The NCCN, very reputed cancer guideline, they have recommended to start the breast cancer screening at the age of 25 years of age. Screening method may be vary when we grow older, but screening has to be started at the age of 25 years of age. So if you get females in the whole world, as far as the breast cancer is concerned, they can be divided into two main categories. They can be either average risk for development of breast cancer, or they can be either increased risk for development of breast cancer. There is no female in the world who has no risk for development of breast cancer. Either they are average risk or the increased risk. So increased risk, the females who has the increased risk for the development of breast cancers, who has the additional risk who has the additional risk factors for development of breast cancers. Who the female who doesn't have additional risk factors, they come into as the average risk for development of breast cancer. So as I said previously, we have to start the screening at the age of 25 years of age. So what are the screening methods that you have to start at the age of 25 years? First thing you have to do is, at the age of 25 years, you have to be examined by a qualified medical professional. It can be either breast cancer nurse or surgeon or oncosurgeon, or whoever qualified doctor has to be examined by the age of 25 years of age and exclude any sort of abnormality in the breast. And thereafter, if you don't have any risk factors, you can visit the doctors each once in every 3 years. So you go to the doctor and examine the breast by 25 years of age, and every third year you will go and examine until you come to the age of 45 years of age. But once you come to the 40 years of age, you have to undergo something called screening mammogram. So in the other countries, they are recommended to do the screening mammogram everybody at the age of 40 years of age. If you don't have any additional risk factors, it is okay to repeat the screening mammogram once in every 3 years. But if you have increased risk, you have to repeat the mammogram annually. So it's so simple. You go to the doctor by 25 years of age, and every third year you go to the doctors until 40 years of age. And since then, you have to start the mammographic screening once in every 3 years if you are average risk, and if you are increased risk, you have to do it mammogram annually. That is the first screening method that you have to do. Second thing is breast cancer awareness. That means female has to know about their breast. They have to know in and out about their breast. So the size, the texture, nature, skin, everything, they have to know about their breast. So to do that, they have developed something called self breast examination. So I am going to talk about a little bit in the next couple of slides about the self breast examination. As females, you should know about to do the self breast examination, as well as health professional, you have to know how to do self breast examination, and you should be able to teach to the general public as well. So whom to screen? All the females above 25 years of age. So keep in your mind, it is not 40 years, if it is not 60 years of age. All the females above 25 years of age has to go for the breast cancer screening. So what are the high risk factors for the development of breast cancer? Any family history of breast cancer, colorectal cancer, ovarian carcinoma is a risk factor for development of a breast cancer individual. And increasing age, especially more than 40 years of age, that's why we are implementing the mammographic screening. Lifestyle factors like increased body mass index, increased alcohol consumption, and current or prior estrogen and progesterone hormone agents. When I say estrogen and progesterone hormone agents, sometimes people have the question of whether the oral contraceptive pills will cause the breast cancers. The theory behind is like this: breast cancer development occurs due to the estrogen effects on the breast. So mostly in other countries, especially the developed countries, oral contraceptive pills are progesterone dependent. But in Sri Lanka, it is combined oral contraceptive pills, which has the estrogen and progesterone, and both are there. When you get the progesterone-based oral contraceptive pills, there is no sort of high risk for development of breast cancer. But when you get the combined oral contraceptive pills, there is still very little evidence for development of breast cancer. Mainly, we are talking about the estrogen replacement after the menopause, that is hormone replacement therapy. I think you understand that. So the person's reproductive history, if the female's breast is exposed to increased period of estrogen, like very young age of menarche and the late age of menopause, there is a long duration of exposure of breast to the estrogen produced by the ovaries. So that is a risk factor for development of breast cancer. At the nulliparity, old age at first live birth, all these are risk factors for development of breast cancer. Other risk factors like history of lobular carcinoma in situ or atypical ductal or lobular hyperplasia, number of prior breast biopsies, and increased mammographic breast density. If your breast density is high according to the mammographic, there is a increased risk of development of breast cancer. And prior thoracic radiotherapy for any other reason less than 30 years of age, again it is a risk factors for development of breast cancer. Previous history of breast cancer. Now suppose if somebody has developed breast cancer in one breast and treated for that one, that patient has a high risk for development of breast cancer in the other breast, contralateral breast. An absence of breastfeeding, and lastly but not least, genetic predisposition. Some females carries the genetic abnormalities such as BRCA1, BRCA2 genes. If you are detecting BRCA1 or BRCA2 genes, mutated genes, there is a very high chance, more than 60%, 70% chance that this particular person is developing a breast cancer and the ovarian cancer by the age of 50 years or 60 years of age. So there is a very high chance of development of breast cancer. In such patients, we offer prophylactic mastectomies. In the left corner, the lady, I think everybody knows who she is. She carries the BRCA1 gene, and she has been treated with bilateral mastectomies and reconstruction. So I have talked about the patient-centered screening tools such as self-breast examination. So how do you do that? Everybody should know about how to do self-breast examination. It has to be done monthly. It has to be done regular intervals. You should avoid doing self-breast examination during menstruation. You know, during the menstruation, breast get engorged, and you might not feel the lumps inside the breast. And you use your pads of the fingers, and you have to feel all four quadrants of the breast and the armpit area. You can do in several ways. You can go circular manner, you can go up and down repeatedly, or you can palpate the breast in the quadrant wise. Whatever the way you are doing, you have to make sure that all four quadrants are palpated and feel and the armpit area as well, and feel for any abnormalities. You can do it in the shower, in the standing position in front of the mirror, then you can see your breast properly, or else you can do in the lying down position. Ideally, you have to do those self-breast examination both standing and lying down position. A clinic-based screening tool, as I said previously, you should go to get the breast be examined by a doctor starting at the age of 25 years of age, maybe 3 yearly or less than 3 years depending on your risk level. And after the 40 years of age, you have to go for the screening mammogram. And other screening methods some people are using is the MRI scan. MRI scan is we are using for the screening method only if the patient is very high risk. Suppose now the patient is diagnosed with BRCA1 and BRCA2 gene. In such individuals, we go for the MRI scan screening starting at the very young age, maybe 16, 17, 18, or early 20s. And the Western culture, Western society has developed some risk models that predicts the development of breast cancer in individuals. Some risk models are largely dependent on the family history, and some risk models are developed who does not have a family history of breast cancer. So you can see all these risk models. You can search in the Google, and you have to enter certain data regarding you age and BMI, and whether you have a family history, likewise any other risk factors. When you enter all this data, they will give you a risk, how much risk you will have a development of breast cancer in the next 5 years, 10 years, or 20 years. So such risk models are BRCA Pro, Tyrer-Cuzick. Those are mainly based on the family history, and something called modified Gale model that is based on the on patient who doesn't have a family history of breast cancer. Before development of breast cancer, who has the very high risk of development of breast cancer, there are some risk reduction interventions you can do. So you can have a healthy diet, lifestyle modification like healthy diet, exercises, reduce body weight, and reduce alcohol intake and smoking. And some oncologists are using the tamoxifen and aromatase inhibitors. That is not individual based, it is solely individual basis. Some people are using, some people are not using. And we can go for the risk reduction surgeries like bilateral mastectomies or bilateral self-injure oophorectomy to reduce the estrogen drive that give rise to development of breast cancers that we have discussed previously. Right, that is regarding the screening. So how to increase the increase the access to the medical treatment? How can we make it easy for the general public to access the medical treatment for as far as the breast cancer is concerned? I think you might be aware. Some of you might be aware regarding the something called breast clinics. This is actually a national program which is conducted by the National Cancer Control Programs. So certain hospital has something called breast clinics. Now, for example, all the oncological unit in Sri Lanka are conducting a breast clinic. So these clinics are solely confined to the breast and breast related condition. So patient can be referred by the GP, patient can be referred by the OPD, anybody can be referred the breast related condition to these breast clinics. And once these patients come to the breast clinic, the qualified doctors and the nurses will examine and do the necessary investigations for exclude the breast cancers. And apart from the oncosurgical unit, some of the general surgeons who are especially interested in breast also conducting the breast clinic. Especially now, for example, in Batticaloa, we have a breast clinic in oncosurgical unit every Tuesday afternoon. And apart from that one, other general surgeons also conducting individual breast clinics. That is the one thing. Second thing is recently the cancer control program has started another program to increase and easy access of public to access for the breast cancers treatment. That is the cancer early detection center. So they are establishing cancer early detection centers. This is not only confined to the breast cancers. In the cancer early detection centers, they are going to screen for breast, cervical, as well as the oral cancers. So, but for example, in Batticaloa, we have every day in the afternoon, we have a cancer early detection centers in OPD. So people can walk in to these cancer early detection centers and get themselves registered and may exclude whether they have any breast cancers or breast related any pathologies. Those are breast clinics, and the cancer early detection centers are mainly confined into the hospitals. But apart from that, there are community level clinics which is run by the MOHs, that is such as for example Suvanari clinic. So in these clinics also, doctors examine the females for possible breast cancers. If they found to have any suspicious thing, they will refer to either OPD or directly they can be referred to the breast clinics. I think fairly we have a very good access and easy access for the public to get the medical treatment as far as the breast cancer is concerned at the moment. So that is regarding the things that happen before the development of breast cancer. So prevention of the breast cancers. So how to identify a breast cancer? These are the main thing that you will encounter when you are doing the medical treatment day to day life. I would say like this. Now, any changes in your breast shouldn't raise the suspicion of breast cancer. It may be breast pain, it may be any breast lump, it may be any changes in the skin. It may be inflammatory changes like powder orange appearance, dimpling, swelling, any ulceration, any changes of the breast, any redness, any discharge, any sort of change in the breast should raise the suspicion of breast cancer, and you should get uh, investigated. Now, this is one patient who came to our oncosurgical clinic. You can clearly see the difference between the right breast and the left breast. In the left breast, you can see something that is the powder orange appearance. And apart from the breast, any changes in the nipple, rest of the breast may be normal, but there will be changes in the nipple. Maybe there will be nipple discharge. It may be unilateral discharge. It may be bilateral discharge. It be different colors, red color, brownish color. It may be colorless, it may be milky discharge. Whatever the discharge, or any nipple deviation, any nipple eczema, nipple retraction, destruction, any sort of nipple changes should raise the suspicion of malignancy of the breast. So something called, there is one condition called Paget's disease. You can't see the disease, any lump in the breast, but you can see the changes only in the nipple. Those things has to be investigated. Any axillary lump should raise the suspicion of any breast cancers. Sometimes people are presenting with only the axillary lump. Even now, the oncologists, oncosurgeons, and the surgeons know some people are presenting with only the palpable lump in the axilla. When you investigate for that axillary lump only, you will find out there is a cancer in the breast. Now, if somebody present with such symptoms, is it always confirmed that it is a breast carcinoma? No. Majority of the time, I would say about 60%, 70% of the time, it is not a breast carcinoma. It is a something benign breast disease. But there is a 30% to 20% chance is there that it can be a breast carcinoma. So that is what we are targeting for. We have to exclude that 20% and 30% chance of that symptoms being a breast carcinoma. So there are a lot of benign breast diseases. It can be fibroadenoma, there will be breast cyst, there will be ductectasia, galactosile, there will be infectious disease like inflammatory disease like acute bacterial infections, breast abscesses. There will be a whole lot of dozens of causes for giving rise to symptoms and signs mimicking breast cancer. To exclude those benign disease, you have to examine and you have to investigate the breast properly. So whenever there is a symptom and sign, it doesn't mean that it always become a breast carcinoma. So when such patient comes with the symptom and sign to a medical surgical clinic or oncosurgical clinic, so what the doctors are doing, so I think this one you all know that we go for something called triple assessment. So we go for the detailed history and detailed examination, and after that I am not going to talk about the history and examination, that is a medical student time thing, but I would go for the detail about the rest of the investigation. So once the patient comes to us, and if you are suspecting a breast carcinoma, first thing is to do is to after the history and examination, go for some imaging. So what are the imaging modalities available to us? It can be bilateral breast ultrasound scan, it can be bilateral mammogram, or bilateral breast MRI scan, and I will talk about the CT scan as well. Now current recommendation is, if the patient's age is less than 35 years of age, you go for the ultrasound scan. If the patient age is more than 35 years of age, you go for the bilateral mammogram. But in practice, what we do is, if the patient's age is 35 years of age, we go for bilateral mammogram as well as the bilateral ultrasound both. So it will give an additive detailed description about the breast. So the radiologist can get the information from the mammogram, and he or she can get the information from the ultrasound scan as well, and he can give a better report regarding the breast. The problem of this mammogram here in Sri Lanka is mammogram facility is not that frequent. Like now, for example, for whole Eastern Province, we have only one mammogram machine, only in Batticaloa. So people from Trincomalee, people from Ampara, people from Batticaloa, all people has to come to teaching hospital Batticaloa for get done a mammogram. So some provinces has a very long waiting list. But thanks to our people in teaching hospital Batticaloa, we have 2 days, Wednesdays and Fridays. We don't have such sort of waiting list. If the patient comes today, this week, next week, we can get done a mammogram thanks to our radiologists and the radiographers. But some provinces, the mammogram list is very low. And the worst thing is, even in the private sector, there is no mammogram facilities available in the majority of the provinces. So we have the ultrasound scan and the mammogram, and some of the patients we have to go for the MRI scan. If the patient's age is very like 20s, early 20s or teens like 16, 70s, or the mammographic and ultrasound scan findings are not that much conclusive, then we have to go for the MRI scan. All the other cancers in the body, before going for any treatment, we go for something called staging by doing a contrast enhanced CT. But in breast CA, breast carcinoma, we are doing the contrast enhanced CT selectively. We are not going to do the CT scans for each and every patient who has the breast carcinoma. So if the patient is having advanced disease like very lymph nodes or very large lesion, and you are suspecting distal metastasis by in the symptomatic patient, then we go for the CT scan. Otherwise, there is no need for going for the CT scan for each and every patient who diagnosed with breast carcinoma. So after you complete in the imaging, then you have to go for something called histology or cytology. So we have two options. The conventionally we go for the fine needle aspiration cytology, but increasingly the surgeons and the oncosurgeons and the oncologists are leaning more towards the true cut biopsy. As a policy in my unit, our unit, we are going for the always all the patients with the breast disease, we go for the ultrasound guided true cut biopsy. The advantage of having a true cut biopsy over fine needle aspiration cytology is, one thing is specificity and the sensitivity is high compared to the cytology. That is the one thing, because you get the tissue architecture, not the cells, as in fine needle aspiration cytology. Second most important thing is we can have the receptor status. Now, when you get the breast cancers, you have the receptors like ER, estrogen receptors, progesterone receptors, and HER2 receptors. Depending on these receptors, we can decide on what is the prognosis. Another thing is whether this patient need neoadjuvant chemotherapy before going for any surgical intervention. So that is the importance of having a true cut biopsy. Now, for example, if the patient is having triple negative, there is no receptor expression of ER, PR, or HER2, or if the patient is having HER2 expression, then these particular patient needs neoadjuvant treatment before the surgery. This is not true for the patients who have a very early disease, like T1 disease, less than 2 centimeters, but more than T1 disease, all the patients who has the triple negative disease or the HER2 positive patient need to undergo neoadjuvant treatment before going for the surgery. So that is the importance of true cut biopsy. This is again, there is a bit of a problem in the accessing the medical facilities, but we have to work on as much as possible to always complete the imaging first, mammogram and true cut biopsy before the surgery. So these are some of the mammogram that came to our clinic in Teaching Hospital Batticaloa. You can see in the first one, there are several, I don't know whether you can appreciate, there are some small whitish dots. Those are called microcalcifications. These are pleomorphic microcalcification. These are raising very high suspicious of malignancy. And at the same time, you can see the axial lymph nodes, which are very enlarged and distorted in shape. And the second example, you can see there are some architectural distortion compared to the left breast. In the right breast, there is a architectural distortion. That is again a feature of a breast carcinoma. In the third mammogram, you can see clearly the hyperdense lesion in the right breast compared to the left breast. So what now? The patient comes to you and you took a history and examination, did the examination, took a history, and did the imaging is completed, and the histology, true cut biopsy also done. It is confirmed it is a breast cancer. So is it the end of the world? No, it is not always the end of the world. So there are some interesting things that I can tell you now regarding the breast cancer. The early detection has the complete cure. So if the breast cancer is present at very early stage, there is those patients has the complete cure. And the second thing is majority does not need complete removal of the breast. There is something called breast conservation surgery, which I'm going to talk in a little bit. In that way, we can preserve the breast, and the all the complications occurred due to psychosocial and complication due to removal of the breast can be avoided by adhering to the breast conservation surgery. Even the breast is completely removed, there are a lot of techniques that nowadays available to reconstruct the breast. So I can show you example in a few slides in next couple of minutes that we have done. Even the breast is completely removed and we have done the reconstruction. And majority of the patients are complaining complications due to axial clearance. When you go for the axial clearance to remove the lymph node, patient might have lymphedema, shoulder girdle stiffness, pain, and the axillary numbness. There are a lot of complications due to the axial clearance. So if the patient present in the early stage, majority of cases you can avoid the axial clearance by way of sentinel lymph node biopsy, which I'm going to talk in a little bit. And very early stage, you can still uh, get out with the chemotherapy and radiotherapy as well. So very early stages. Right. Once the patient is diagnosed with the breast cancer, usually in other countries they go for the breast MDTs. But in in Sri Lanka, because of the very high number of patients, very difficult to go for each and every patient of breast MDT. However, once the patient is diagnosed with breast cancer, there are 4 questions that we have to answer in her management in the future. So first question we have to ask: this patient is eligible for upfront surgery, or whether this patient needs neoadjuvant chemotherapy follow before the surgery. That is the first question: whether the patient needs straight away go for surgery, or whether the patient needs neoadjuvant treatment before the surgery. Second question we have to answer is type of the breast surgery. What are we going to do for the breast surgery? Whether we are going for the mastectomy or whether we are going for the breast conservation surgery. Third one is what are we going for the axilla? Whether we go for the sentinel lymph node biopsy or whether we are going for the axillary clearance. And the last question we have to ask is, after the surgical intervention, what are the adjuvant treatment that we are going to do? Whether the patient is radiotherapy, whether the patient is the systemic treatment. So treatment options surgically, I would say for the sake of easiness, I will divide into 3 main categories. Those are the early invasive breast carcinomas, locally advanced breast carcinomas, and the metastatic breast carcinomas. So, but in a scientific way, it is different staging systems are available, like TNM staging, but for the sake of easiness, I would divide all the breast cancers into early invasive breast cancers, locally advanced breast carcinomas, and the metastatic breast carcinoma. Standard of care for the early invasive breast carcinoma, that is stage 1 and stage 2 disease, is the breast conservation surgery. That is called wide local excision. And if the axilla is negative, if the tumor has not spread to the axilla, then we have to offer the sentinel lymph node biopsy, followed by whole breast radiotherapy. It is very important to understand that if the patient has undergone breast conservation surgery, if we have preserved the breast, then we have to make sure that patient is undergoing a whole breast radiotherapy. Otherwise, there is a very high chance of recurrence in the remaining breast. It's about 20%, 30% chance of recurrence of these breasts if you are not offering the whole breast radiotherapy after the breast conservation surgery. So it comes as a package. If you go for the wide local excision, always you have to go for the whole breast radiotherapy. Other options are the conventional mastectomies and level 2 clearance. And if you are going for the mastectomy and breast reconstruction, there are various breast reconstruction method like autologous flaps, like pedicle flaps like tram flap, latissimus dorsi flap, or like free flaps like BF flap, like tram flap means transverse rectus abdomen myocutaneous flap. Latissimus dorsi flap is we are taking the latissimus dorsi. DF flap is we take it as a free flap, deep inferior epigastric arterial perforator flap, and you can use the prosthesis for the reconstruction of the breast. So I want to talk a little bit about the breast conservation surgery because it is a very interesting topic these days. The breast conservation surgery is defined as the complete removal of the tumor with the margin of surrounding healthy tissue and maintenance of acceptable cosmesis. That means we remove only the tumor with the cuff of normal breast tissue, and we have to make sure that the breast is maintained in the acceptable cosmesis. This is the accepted standard of care for the stage 1 and stage 2 breast cancers. And the research has shown breast conservation surgery is at least as equal to the mastectomy in the terms of overall survival and breast cancer specific survival. So the mastectomy as well as the breast conservation surgery has the same overall survival and the breast cancer specific survival. But it has to be very important. After the breast conservation surgery, you have to go for the whole breast radiotherapy. Overall survival and the breast cancer specific survival may be inferior in some patients treated with mastectomy. Some research has shown that the patient who has treated with mastectomy has a lower overall survival and the breast cancer specific survival. But that may be because of we are offering the mastectomy patient who has the very advanced disease. That may be the factor. Patients treated with breast conservation surgery have a better long-term quality of life and functional outcome. We have seen some patient who has undergone mastectomies, their family shattered. Like, when the breast is no longer there, there will be some family problems are there, and there are psychosocial problems are there. Patients get depressed. So all these problems can be evaded by doing a breast conservation surgery. So in our unit, and the most of the oncological unit and the surgeons who are interested in breast cancer treatment, they are more towards leaning towards the breast conservation surgery nowadays. The range of procedures are coronary and wide local excision, and these are some of the breast conservation surgery that I have done in Teaching Hospital Batticaloa. We have done. So this particular patient, you can see in the first picture, the breast cancer is completely removed, and this lower down is the removed breast cancer with the normal margin of breast tissue. And this area has to be marked with the Liga clips, titanium clips, to give an additional boost of radiotherapy during the whole breast radiotherapy. So this the left side, you can see the axillary, very small incision compared to the long axial clearance incision, and we have taken the central lymph node biopsy. This is another breast conservation surgery that we have done in Teaching Hospital Batticaloa. You can see the large area of the breast cancer that we have removed. The patient is having a large breast, lot of breast parenchyma. You can remove very large amount of breast tissue. So very large area we have removed, and we have reconstructed to near normal contour of the breast. There are if you can't primarily close the defect created by removal of the breast cancer, there are various mammoplasty techniques are now people are practicing. There are a lot of flaps are there. So inferior pedicle flap, round block flap, Bisotti flap, LICAP flap. LICAP flap is a lateral intercostal arterial perforator flap. Superior pedicle flap. So these we can use various sort of mammoplasty technique and reconstruct the breast in as near normal as the contralateral breast. This is such a mammoplasty technique we have done in Teaching Hospital Batticaloa. This is called Bisotti flap. So the tumor is in the center of the breast. We have to remove the nipple areola complex, including the breast tissue. So that defect we filled with something called Bisotti flap, and after reconstruction, breast is like near normal to the contralateral breast. And this is called LICA flap. Unfortunately, I don't have the flap raised. The picture of the raised flap, but this is how you do it. This is the area you can see near the lipid complex. It is the tumor is marked here, and the lateral intercostal arterial perforators are marked by our radiologist, and based on those perforators, we raise the flap and tunnel through the breast parenchyma into the defect created by the breast cancer, defect created by the wide local excision. So then we can get a near normal breast contour. Even now, those are the breast conservation surgery. Now, even after the breast is completely removed, I told you that mastectomies can be treated with the breast reconstruction. This is such breast reconstruction we have done in Teaching Hospital Batticaloa. This is called tram flap. So you can see lower down. I have marked areas with 1, 2, 3, 4. This tissue is tunneled through the skin into the area of mastectomy on the right breast, and we can create a new breast as same as the other contralateral breast, and later you have to reconstruct the nipple areola with the tattooing and the nipple reconstruction. And this one again something called nipple sparing mastectomy. In some patients we don't have to remove the skin at all. In those patients what we do is we go out the breast parenchyma only. There is something, then we preserve the nipple and we preserve the overlying skin of the breast, and we go out all the breast tissue making a small incision, and the defect by covering out all this breast tissue is filled with some sort of flap. It can be either latissimus dorsi flap or it can be tram flap. So in this particular patient we have used tram flap to fill the defect created by the covering out of the breast tissues. So this is called nipple sparing mastectomy. Sometimes we might not be able to preserve the nipple, then we have to go for the skin sparing mastectomy, only removing the nipple areola, but the skin is completely preserving. So that is to the breast. So breast, we have the breast conservation surgery, and we have, even we go for the mastectomies, you can go for the breast reconstruction. So it's very important when the patient diagnosis a breast carcinoma, this information has to be told to the patient that these options are available. Then only patient can have a informed consent for the surgery. So we as an oncosurgeon and the general surgeons, we treat the axilla as separate thing. So we treat the axilla as separately. The tumor spread to the axillary lymph node is one of the most important prognostic factors in the early breast cancers. So nowadays people have questions about the therapeutic value of axillary nodal dissection. People say it is mostly have a prognostic benefit rather than the therapeutic benefit, especially with the micrometastasis or the limited macrometastasis. The problem of treating the axilla with axial clearance is nearly 15% of the patient who is undergoing axial clearance will develop upper limb lymphedema. Apart from upper limb lymphedema, various other complications which I have told previously, like shoulder pain, stiffness, numbness, and all these problems occur due to the axial clearance. All these can be get away by doing the sentinel lymph node biopsy. So we offer the sentinel lymph node biopsy. So the treatment option for the axial lymph node, if the axillary lymph nodes are not involved with the tumor cells, that is, now if the tumor is not spread to the axilla, if the axillary lymph nodes are negative for tumor cells, then we have to offer something called sentinel lymph node biopsy. If the axial lymph nodes are there are palpable lymph node, then the guided FNS is positive for cancer cells, then we have to offer the level 2 axial clearance. That is no doubt about that. But if the axilla is negative, then we have to go for the something called sentinel lymph node biopsy. So during the sentinel lymph node biopsy, there are different methods there are tracer, like two tests we are using. Either we can use the methylene blue, or we can use the radiopharmaceutical tracers like radiolabeled colloid, or else we can use combination of two. But a radio-labeled colloid is not very frequently available in Sri Lanka. So I have seen in Maharagama when we are doing the senior registrar period, cancer hospital, but in all the other areas, I don't think it is freely available. So we use the methylene blue. What we do is, before the surgery, we inject 3 cc of 3 ml of methylene blue in the subalveolar region, and we give a good breast massage, and we make a small cut at the axillary region and take the first lymph node that is stained by the methylene blue, and we send that sample for frozen section or histology. In Batticaloa, we have established the frozen section. Sentinel lymph node biopsy, thanks to our consultant histopathologist. If that lymph node is positive, then we have to go for the axial clearance. Otherwise, we have to we can avoid doing the axillary clearance. By saying all these fancy stuff regarding the breast cancer surgeries, all these are having the complications. So these are some of the complications that I have encountered in teaching hospital Batticaloa. It can be bleeding, infections, seroma formation, lymphedema, axillary numbness, and shoulder stiffness and pain that I have told. Now you can see this in the lower down there is a wound breakdown. So that is because of the injection of methylene blue. When you inject the methylene blue subareolar region, sometimes it might cause the skin breakdown. In the lateral photo, that is after the mastectomy, patient has developed a hematoma. So we have to take the patient. HB has dropped to 6. Then we have to take the patient for the hematoma evacuation. So these complications might occur on and off. So what are the advices you should give to the patient after going for especially the axillary clearance? Now these are the things that actually you have to know when you are advising the patient after the surgery. So you can have a shower normally after 1 week. You can use deodorants or axillary perspirants after about 2 to 6 weeks. And if the patient has any sort of discharge, new swelling, heat, redness, or any signs of inflammation, rash around the wound, any fever, patient has to come as soon as possible and contact the operating doctor. And there are things that you have to do to prevent the lymphedema after the axillary clearance. So I know this is a bit crowded slide, but these all are important. So whatever all the things are aiming towards to reduce the lymphatic drainage from the affected limb into the general circulation, because we have removed all the lymph node in the axilla. So if you increase the lymphatic drainage from the affected limb, that will create, because there is no escape from the axilla because all the lymphatics has been removed, and there will be uh, development of lymphedema. So you can have to avoid carrying heavy weights and avoid heavy and repetitive tasks. People asking about the sexual activity after the surgery. You can do when you feel able, but give yourself some time and do not expect too much. No swimming for at least 6 weeks to 6 weeks after the surgery. Do not drive for at least 3 weeks after the axillary clearance. Avoid hot bath, applying hot packs on the affected limb, which will increase the lymphatic drainage from the affected limb. Maintain healthy weight, and wear supportive full cup non-wired bra. If you wear the very tight and wired bra, what will happen is it will again prevent the lymphatic drainage from the affected limb into the main circulation. Avoid injections, blood tests, and blood pressure measurements from the affected limb. I think we all know all these things, but you have to educate the people about these things. Prevent any sort of cuts and insect bites, and you can use the gloves, and you can use insect repellents. Uh, you can use keep your arm and breast on the affected side well moisturized. That will prevent the cracks which is happen due to the dryness of the skin. And you can use high factor sunscreen to protect from the sunburn when you go out. You have to avoid wearing clothes or jewelries that are too tight on your affected arm. So these, and especially if the patient is having pets, cats and the dogs, you have to make sure that they are not scratching on your affected arms. That will give rise to inflammation and increase the lymphatic drainage from the affected limb. So these are some of the important informations that you have to give to the patient who has undergone axillary clearance. So that is the early invasive breast carcinomas. So these, when you move on to the locally advanced breast carcinomas, usually they need the neoadjuvant chemotherapy before the surgery. So when you say the locally advanced breast carcinomas, either they are attached to the skin or the underlying pectoralis major muscles, or there is a large lymph nodes, more than 2-3 lymph node fixed nodes in the axilla. In those patients, we have to go for the neoadjuvant chemotherapy before going for the surgery. So mostly after the surgery, they end up in doing the mastectomy and axillary clearance. Compared to the early disease, locally advanced breast carcinomas prognosis poor, and they are having a bit of a troublesome time after the surgery because of the chemotherapy and radiotherapy and all the other complications. This is one of the very advanced breast carcinoma presented to us. All the breast is involved, and we couldn't do the mastectomy and approximate the skin edges. Then we have to use flaps. This patient had a latissimus dorsi flap, and overlying that one, we have to use skin grafts. The patient is doing fine at the moment, but actually fine in the sense now patient has developed another cancer in the other breast. We patient had underwent a control mastectomy as well recently. So that's why I told, when you have a locally advanced breast carcinomas, there's a bit of a complicated life after the surgery. This is another recurrent breast carcinoma presented to us. This patient actually initially treated with breast conservation surgery and whole breast radiotherapy, and it has been treated for this wound, considering this is as a radiotherapy induced wound, for 9 months. So then she presented to me, and we had to do a biopsy and all the staging and all. Biopsy came as recurrent breast carcinoma. So we had to offer the palliative. We have to offer the mastectomy. I told palliative because when your investigation for this patient, this particular patient had lung mets. So recurrent breast carcinoma usually end up in mastectomies. But before going for any surgery, we have to exclude distant metastasis by doing a contrast enhanced CT. These are extreme cases of recurrent breast carcinoma. This particular patient had wide local excision previously. This time presented with the recurrent breast carcinoma at the medial edge of the breast, involved in the thoracic cage, sternum and manubrium, and the rib cage. So we had to remove the thoracic 2 ribs and the part of the manubrium and the part of the sternum, and reconstructed with the bone cement. I don't know whether you can appreciate. I am holding here is a part of the lung. This one again, another extreme case of recurrent breast carcinoma presented to us. You can see the area is marked here, which actually this one we have done last week in Tuesday with the help of thoracic surgeons. Now you can see in the CT here, there is a recurrence of breast carcinoma, and we had to remove that part, including the manubrium, sternum, and the part of the ribs. And this is the video. You can see the pulsating pericardium and the lungs, and that area we reconstructed with the bone cement and the mesh. This is another extreme case of breast carcinoma. These are called inflammatory breast carcinoma. If the patient has a very short period of breast pain, engorgement of breast, and whole inflammation of breast, these are very aggressive tumors. These shouldn't be touched primarily for surgery. This should always go for the neoadjuvant treatment before the surgery. And this particular patient we have referred for the neoadjuvant treatment after the investigation, and then we have to offer the mastectomy and axial clearance. But compared to the early breast carcinoma, this has a bit of a bad prognosis. This is again metastatic breast carcinoma. This patient has a very large ulcerated lesion in the breast, and the metastasis in the lungs and the bones and the liver as well. We offer the surgeries only for the metastatic breast carcinoma only if the patient is having a very discomforting ulcerative lesions. Otherwise, hardly any place for surgeries who has the metastatic breast carcinoma. Main mode of treatment of the palliative chemotherapy. The previous patient, metastatic breast carcinoma patient, when the patient referred to me, we have offered the surgery considering his large wound, but about a couple of days time, patient has died because of the metastatic complication due to metastasis. So that is very poor prognosis of this metastatic breast carcinoma. This is another case, very rare presentation. This is a male breast cancer. Less than 1% of the whole breast cancers are presented as the male breast cancers. Management is same as the female breast cancers, except that we don't offer the breast conservation surgery because there is no breast tissues, enough breast tissue to offer the breast conservation surgery. So we always go for the mastectomy and the axial clearance or the sentinel lymph node biopsy. So those are the surgical management of the breast carcinoma. After we do whatever all these surgical treatment for breast carcinoma, we go for oncological management. So once the histology report is available, we refer the patient for the clinical and our clinical oncologist. So they will start the adjuvant chemotherapy or adjuvant radiotherapy or adjuvant hormonal treatment depending on the histopathology report. I think it is the adjuvant oncological management should better be dealt by the clinical oncologist rather than the surgeon is doing that one, because it will be more sort of detailed by doing them. So I suggest Sri team to organize a lecture by the clinical oncologist on the breast cancer neoadjuvant and adjuvant management as well. So follow up after the surgery. Usually the objectives of this follow up is to detect the salvageable disease recurrence and the manage the treatment related complication. So I think I want to tell you one thing here. Then all the world has separate guidelines for management of cancers, and Sri Lanka has developed a separate guideline for Sri Lankan setup for breast cancer management, which is headed by Dr. Raj Joseph, consultant clinical oncologist, and there are a lot of consultant oncosurgeons, general surgeon, and oncologists are included in that panel. So these follow-up plans are depending on their recommendations. So clinical breast examination every 3 months for the first 2 years, and thereafter every 6 months for the next 3 years, and annually thereafter. And they have recommended the annual mammogram for first 5 years following the completion of treatment. And you have to do the bone mineral density, that is bone scan assessment, annually in patient treated with ovarian suppression or the aromatase inhibitors. No evidence for routine blood investigation. They say that there is no evidence for routine blood investigation, chest radiographs, or ultrasound scan during follow-up, and they discourage that one. So I suggest you to go to the internet. It is available as a PDF format. There is a separate guideline for breast cancer management in Sri Lanka. And it is not only the medical professionals work for treatment of breast cancer. We have to always combine and collaborate with the non-medical organization. This is one such organization that is closely relating with the oncosurgeons and the general surgeons who are especially interested in breast cancers and the oncologists. And this is called Indira Cancer Trust. We are the main head office is near the Apeksha Hospital. They are giving lot of social services. They are now, for example, they are delivering the mastectomy bras for the whole of the Sri Lanka free of charge, and there are whole other financial social support for the females who has undergoing breast cancer. So breast cancer fight, the fight against the breast cancer, the person doesn't have to fight alone. There are a lot of social support is around Sri Lanka. There are so many other social organizations are there, but this one I have included because this is closely related to us. So that concludes my lecture. Any questions? I think it is a time to ask the questions at the moment.
Yes, sir. Thank you very much for your very informative lecture. I think you have covered all the important aspects, and it was a very quite long lecture covering all the important aspects. I have some questions which were sent by the viewers before the commencement of the lecture. I think we have one question in the chat box also. We'll get to that first. What is breast reconstruction done at the same time of total mastectomy and found to have positive margins in the histology?
So that is a bit of a good question. These things happen actually. That is why we have to practice always. There is another countries what they do is during the surgery they will send the additional margins, inferior margin, superior margin, lateral margin for the frozen sections to make sure that the tumor is completely removed. In these situation, if some margin is positive, that is sort of like collective decision. Then you have to discuss with the oncologist, you have to discuss with the patient, you have to discuss with the histopathologist. It's a combination of we get the all people's thing and explain to the patient the options available is available options are. One thing is you have to go for you can go for the radiotherapy and chemotherapy, adjuvant chemotherapy without doing for any further intervention, any surgical intervention. But if the oncologist is saying that that we need to have a clear margin, then surgeon has to go again, and if you know the margin that is positive, then you can remove that area and reconstruct again. Then you have to offer to the oncologist for the further oncological management. But in practice, you should have at least you should have a discussion once these things happen with the oncologist and as well as the patient, because when the margin is positive, when you go for the chemotherapy and the post op radiotherapy, then you can have a close follow up with the patient, and whenever there is a recurrence there, then we can go ahead and remove that drug. But if the oncologist says that we need a negative margin, then as surgeons we have to go again, remove that area and give them a negative margin.
Thank you, sir. There's one other question. Do we need to go for a biopsy for a radiologically benign lesion in a patient who has positive family history, like fibroadenoma in a young girl?
Exactly, yeah. Now what is the policy of in our unit, in my unit is, and most of the guidelines also say that if the patient's age is more than 25 years of age, or the 20 years of age, more than 20 years of age, even the clinically and radiologically it is fibroadenoma, as a policy we confirm it is by histologically, either by true cut biopsy or fine needle aspiration cytology. If the patient is having a positive family history, there is a definite place for the histological assessment, confirm it is as a benign nature before going forward. So, but even the patient doesn't have a positive family history, our unit practice is to be more than 20 years of age. If clinically positive, if clinically benign or the radiologically benign, we always go for the histological proof that it is benign to manage before it is managing conservatively.
Okay, right. Thank you very much, sir. The other questions we have already answered in the lecture, which was very informative. We have covered all the aspects. I again thank you on behalf of Sri for your time invested in this conducting this lecture and the service you are currently doing for the country. Thank you very much again, sir. Dr. Buddhika Thilakarathna, consultant oncological surgeon, teaching hospital Batticaloa for today's lecture, the breast cancer. And I invite all of you to fill the link which was posted in the chat box and get your e-certificate and the CPD points. And I invite all of you to join with us again on next Sunday with another interesting topic. Thank you very much and have a good day.
Thank you very much. Thanks a lot.